So what we're going to talk about today are some of the issues revolving that transition in the healthcare system. So it is a part of the healthcare services, but it's something that hasn't been widely addressed or discussed with some of the issues that occur. So we're going to start out by talking about why everyone should be concerned about what happens in the hospital. And then we'll talk about some solutions. So the family experience, things that everyone can do to help prepare for hospitalization, and then we'll leave you with some very specific tools. I did want to say that there is some different terminology. We're using Neurodevelopmental Disability, NDD, that's the standard for the SED and the LIND. But some of the research that's done refers to intellectual and other disabilities, developmental disabilities, and then particularly in England and Europe, they use the general term learning disabilities to sort of reference what we're talking about is neurodevelopmental disabilities. So in the slides, you'll see a little bit different acronyms, and that's just because I'm honoring how the researchers themselves did that. So why should we all be concerned about this issue? Well, here is something from 2001, and I point that out to say that I think it's well past time that it needs to be revisited. The U.S. Surgeon General's office put out this study that recognized that there were issues and problems, called for there to be national standards for healthcare and services, and that we needed to standardize patient care and actually monitor and look at safety and outcomes. And this report was done because a group of advocates went to the federal government and had a pretty sizable list of adverse events that had happened in the hospital. But here we are now. It's 18, 19 years later, and this hasn't been revisited or looked at. In 2009, there was a survey done for persons with disabilities, asking them about their healthcare experiences. And what they were able to garner from this survey is that a person with a neurodevelopmental disability, because of some innate issues within that disability, are more likely to have complex care, more likely to have other conditions that happen, say, such as seizures. There was limited access to health care, there were missed cancer screenings, poorly managed chronic conditions, and a lot of everyday kind of health matters and conditions were undetected and unnoticed. More frequent ER visits, longer waits, and more hospitalizations, and then a lot of missed vision and mental health issues. So again, this is in 2009. This report went out to the medical schools, nursing schools, healthcare providers saying we need to do better, we can and should do better, and it's now been 10 years. So the question becomes, where are we today? These are the studies that were out of Europe. They're called the Sibbald studies, and they went into hospitals, found the admissions related to developmental disability, and then they looked at the outcomes for those persons, and they found some pretty startling results. 30% avoidable death. Just think about that for a minute. 30% avoidable death. A lot of missed kinds of care that I'm going to talk with you a bit more about. And they ended up titling this report Death by Indifference. There was a lot of actual unintentional neglect, a lot of not tending to basic needs. And it was startling. It was picked up by the national press in both England and Europe. A lot of conversation about it. Professional groups got together. And only in one place was something better when they repeated this study in 2013, and that was in the country of Ireland, who actually put a big national effort toward doing better with acute care hospitalization. Otherwise, not only did things not get better between 2008 and 2013, it got worse. So they put out another cry, another hue, another statement about this, and hoping that when they repeat this study, which is actually due to be done next year, that perhaps things will be better. So altogether, we know that there's problems with providing safe and effective care. A lot of this is due to just general language barriers. communication challenges and issues. Sometimes there's missteps and miscommunication just around those basic factors. This population is less likely to have general health care, general prevention, the kinds of things that could kind of keep you out of the hospital to begin with. Difficulty with insurance, finding a trained provider, transportation. I mean, none of these things are going to be new to you, but they have been quantified pretty clearly. And one of the issues we want to talk about today is just insufficient preparation for healthcare providers. There's really very little in medical schools and nursing schools around this, and Dr. Donahue is going to give you some more information about that and actually some good news. So are we doing any better now? Well, in many ways, yes. I think there has been a concerted effort across the nation and amongst professionals under the leadership of things like UC Davis Mind Institute, the SED, and the LEND to address many, many, many of these issues. However, hospital care continues to be problematic, and there continues to be some very significant safety concerns. So what's the research telling us about, say, in the last 5 to 7 years? Well, the top 6 reasons why adults are admitted to the hospital with neurodevelopmental disabilities, and the reason why we focus on adults today is that in general, pediatric care for children with neurodevelopmental disabilities tends to be much more organized. There's a lot done to kind of help kids get in and out of the hospital, especially at the pediatric network hospitals. However, if you take one step away from those major university centers, all the problems that I'm talking about and concerns actually do apply to children too. So the number one reason for admission was psychiatric disorder, followed by seizures, seizure disorders, pneumonia, other respiratory disorders, GI disorders, and septicemia. Now the reason why we point this out is because this is a very different number one reason for admission in the typical adult population. The number one reasons are cardiovascular disease, congestive heart failure, diabetes, surgery, elective surgery, and trauma. So that's what the healthcare professionals are really expert at doing. Very few nurses are working on units where they are cross-trained with psychiatric issues as well as medical surgical issues. And yet persons with developmental disabilities will not be admitted to the psychiatric hospitals if it's even necessary because of the medical co-founding conditions. And so you have sort of a very big mismatch in that way. And particularly the issues with seizures and seizure disorders are treated and need to be cared for quite differently than, say, an adult that's typically presenting with seizures. And the most common reason for that in the typical population is actually drug and alcohol withdrawal. So a completely different kind of thing when someone's coming to the hospital with these conditions. We do know that there are more emergency room visits, again, because lack of preventative care, chronic condition management, seizure management and control, higher level of care required during admission, so much more ICU utilization. You just know how chaotic those environments are. Higher rates of acute care hospitalization in general. Healthcare providers really struggle with what to do, how to do it, and really with communication and trying to get a lot of needs done. So much of this care becomes sort of turfed to whoever the care provider is that seems to be closest to the person with the admission at the time. And the families start out being very fearful because it's pretty clear that the healthcare providers need more training in this area. So the more hospitalizations you have, the more you are at risk of having an unintended death or risk. So it's almost like I'd say like a perfect storm. There's a lack of preventative care and access to care that can kind of keep you out of the hospital, so you're having more hospitalizations. You already have conditions that lean in toward having more hospitalizations, and the more you're in the hospital, the more likely things are to go wrong. HESLP in 2014 actually looked at 247 deaths. This was on the East Coast in the United States and found 30% of them of adults were avoidable deaths. So seems to be, it's pretty consistent and mirrors with what we found before, and also mirrors what's happening in Europe. So that's more than 1 in 5. That's a really big concern, and that's why we started this question, like, why should everybody be caring about this? Because the risk factors are pretty significant. They aren't getting their medication, the correct medication. Only 12% are getting the correct medication, and only 22% are getting their medication on time. And some of that is just administration of medication. The nurse doesn't know how to talk with the person with autism or their family to talk about how that medication can be administered or what other options there might be. Or even knowing from a caregiver's perspective, like, well, if we use white pudding and we put the pill in the white pudding, we can have the medication delivered. So instead, it just doesn't get delivered at all. And in some cases, that has very severe consequences. For example, if you're there to have your seizures controlled. 18%, that's almost 1 in 5, actually suffer from dehydration during their hospitalization. So they're not being monitored for having adequate fluid. And this is very important because dehydration often complicates many of the conditions for which they're being treated to begin with. It complicates seizures, but it also puts them at higher risk of getting a generalized infection and sepsis, which is one of the leading causes of death in the hospital. And 39% were not brought to the bathroom on time. And you have secondary issues with that, not the least of which are bowel obstruction and bowel impaction, if no one's really paying attention to the GI needs. But this is a basic need, right? The right to go to the bathroom when you need to go to the bathroom. But they also found about 40% did not get daily baths, and I think 90% did not get any oral care, toothbrushing, or any of those other basic needs met during their hospitalization. So there's a big mismatch going on with just kind of standard care. So what do we find out with focus groups of persons that have been in the hospital with neurodevelopmental disabilities? And here's what they tell us. They're very fearful. It's an unfamiliar setting. I think everybody is a little bit afraid when they go into the hospital. But what they pointed their fear toward is that I don't think anybody here knows how to take care of me. And I feel unsafe. I don't feel safe being here. They have difficulty communicating their needs. There's not a lot of support for that within most hospital systems. The medical and nursing staff seem to lack training. The individuals comprise 1 to 3% of the general population, and yet 6% of the seizures. But again, the way that you treat the seizures and think about the seizures is really very different. People specifically for persons with autism, 53% experienced restraint use in the ER and in the hospital. So one of the very sad things that I witnessed as a nurse was a young woman with autism. She was about 24 years old, and she had quite a bit of communication challenges. Her mother was with her, but her mother had to go down and get a meal and run some errands and stuff. And while she was gone, the nurse had an interaction with her that didn't go well. So she started becoming very frustrated, very agitated. Eventually this evolved into violence. She pulled out her IV. She took the IV pole. She threw it at the nurse. The nurse was screaming and yelling back at her. Many people ran into the room. Things went downhill from there. They eventually physically restrained her, gave her large doses of medication to restrain her. She vomited, she aspirated, and she died. And if this was the only time I'd ever heard about this, I probably wouldn't have been motivated to go into this area and really talk about what we need to do to help care be much safer in the hospital. And this is part of that 30% unintended death and kind of how it happens and things don't get noticed. I do want to talk a little bit about these hospitalizations and ER visits. Their charges are usually 3 times higher, and there's co-pays, there's fiscal issues for the family with this. If you're working and you have to spend all this time going to the hospital trying to get your seizures under control, you're losing your job, your employment. All those kinds of things are impacted by how well and how quickly we can get people in and out of the hospital safely and effectively. So what are some of the unintended harm? They had a hospital, and this is work from Sarah Ailey. She's at Rush University, a very well recognized international nurse researcher in this field, and has put together so many great programs at Rush, and we'll share some of those toolkits with you. But in this data and studies that she's looked at, she found out that 7.1% had a hospital-acquired infection. That's compared to 1% in the typical population. Pressure ulcer or skin damage, about 4% or so. That's compared to 1% in the general population. Post-surgical complications, 4% compared to 0.5, 0.5% in the general population. Medication reactions, about 6% compared to about 2%. Falls, about 3% compared to about 0.5%. So you can see there's just a lot more risk for some of the untoward events that happen in the hospital, and just an overall higher complication rate. Most of these are due to missteps and miscommunication. Again, we know that families are telling us that they're fearful in the hospital, and when they interviewed both clinicians, this is a study where they interviewed clinicians and they interviewed families from the same hospitalization. And the thing that they teased out is that the families and individual patients were saying, wow, I really felt afraid when I was in the hospital. I had a hard time getting my basic needs met, my basic communication needs met. And the clinicians actually indicated that very often they made decisions based on their perceptions of the quality of life of the individual in the bed before them. Like, I don't have to be really, really aggressive because after all, this person has cerebral palsy and they don't really communicate very well. Maybe I'm just not gonna do as much. And it's a little bit heartbreaking to say as a professional to think that that might be a bias or an attitude, but this data actually came from the clinicians themselves. It was an acknowledged thought, almost in the way that you would think someone that was very, very elderly and kind of coming toward the end of their life. That's kind of the viewpoint that they might take of a 25-year-old with cerebral palsy. So pretty, lot of work to do. These are comments and quotes. They're looking at our disability. They don't see you as a person, as a patient or something. They look at us like we don't have brains. Right away, if you're chair-bound, you can't think. Nurses and doctors think that you're sick already, so what's the use? What benefit could there be from care? Iacono did a systematic review looking at all the literature that he could find from all the studies on persons with disabilities in the hospital, and these are sort of the major findings. These failures appear to arise from a lack of knowledge of staff. So they just aren't prepared. It's not that they don't care. It's not that they don't want to do a good job. They're not prepared. They don't have the knowledge. And when you don't have knowledge, you also become fearful and you don't know what to do. So sometimes you do nothing. The difficulties have contributed to the fear and the issues that are occurring in the hospital. However, I kind of did find some really rays of light. There are some hospitals that are providing exemplary care that can become models for the rest of other hospitals across the United States, but unfortunately, this was really the exception rather than the rule. So the one last component I want to talk about, which also confounds this whole situation, is this term of diagnostic overshadowing. And what this means is that the clinician sees the disability and doesn't see the person. So let me give you a couple examples of this. This was a situation that I was involved with a few years ago. An 8-year-old boy who has autism, non-communicative, but has a lot of verbal communication. Everybody communicates all the time, right? And the mother knew he was very sick. He wasn't acting himself. He didn't eat. He kept pointing to his abdomen. And when he got into the emergency room, the emergency room doctor said, oh, your child has autism, they're doing this, that, and the other thing, this is just a manifestation of the autism. I can't feel anything in the belly, and so we'll just, give him some medication to calm him down, and send her home. By the way, when she gets him home, I think his fever was like around 101 on that, so something was going on, right? But just treat the fever. So comes back some hours later, and this time the mother does something which actually has been found in a study by Autism Speaks. They will hide their condition. So she doesn't tell the emergency room doctor that her child has autism. She just says he's in so much pain he's not communicating. Well, the doctor looked at this child in a whole different way and suddenly started working up this kid for appendicitis, which actually turned out to be the diagnosis. Went in, had a successful surgery, and avoid that complication. But persons with disabilities have learned to hide their diagnosis. They may hide they have seizures because they need that person to see them and not their disability. And this problem with diagnostic overshadowing has been well documented in the literature for years. So it's another confounding issue. One big place that we see this too is with generalized infection or sepsis, which is a leading cause of death in the hospitals and the community. And there'll be the typical signs. There'll be fever, pain, complaint of chest pain, really significant changes in behavior, and that will all be explained by just saying, well, they're always like that. And then these issues, these subtle signs of sepsis in the early time when you have a good chance to treat them are missed. Okay, so I had the unfortunate job of giving you all the bad news about the situation and why we should all care. But I want to just tell you that there are a lot of reasons that we can work together, do better, be better. There's lots of ways that we can all advocate to improve this situation. And again, we want to leave you with just like a toolkit that you can use for yourself, your family, your loved ones, your students, clients, etc. We can make better health outcomes, we can improve quality of life, we can lessen the burden on support staff and families, we can reduce economic strain, and we can keep persons with neurodevelopmental disabilities employed in their job instead of in the hospital. So we're delighted today that we have Doreen here. We'll let her introduce herself to you, but she actually has a very unique position in that she is the special needs nurse at St. Joseph's Hospital in Dignity, and she's going to tell you a lot about what services can and should be done in the hospital. So come on up.
Good morning, everybody. I am really happy to be here to share all of this information with you that I have. My name is Doreen Story, and as Diane said, I am a nurse at Dignity Health, St. Joseph's Medical Center in Stockton. I've been a nurse there for 33 years. I am originally from Ohio, so I've actually been a nurse for about 40 years. And I have a son who has Down syndrome. This is my son, Danny. He's got several nicknames, Mr. Smeed, Danny Boy, Officer Dan, he's got all these nicknames. But I actually had my son at the hospital, the very hospital that I work at, and when I had him, I was isolated from all of the other new mommies. I did not know that he had Down syndrome when I was pregnant. And so for probably 4, 5, 6 hours went by after I had him. And when I initially gave birth to him, I was told, oh, healthy baby boy, he's got 10 fingers and toes, he's crying. We're going to whisk him off to, get him cleaned up, and we'll bring him right back to you. Well, 4 hours go by, 5 hours go by, 6 hours go by. And a nurse comes into the room, and she actually happened to be a friend of my husband's from high school. And she said, has the doctor been in to talk to you? And we're like, no, what's going on? When do we get to see the baby? And she said, well, there's something wrong with him. And we're like, well, what's wrong? What do you mean, what's something wrong with him? And she said, well, we don't really know for sure, but I think, she said, me personally, just the way he looks funny. And she said, I think he might have Down syndrome. And so this was the presentation that, we got. And I thought, well, gee, How about congratulations on your new baby, number one, you know? And I said, wow, that's a lot to handle. Okay. So then she walked out of the room and she said, I'll see about getting him brought into you. So then another hour goes by and I send my husband out, go to the nursery and find out why I can't have my child. And so he comes back and he said, well, now they're saying that there's a cardiologist looking at him because he's got some heart problem. So the heart problem that he had is congenital heart disease, and he had a condition called tetralogy of Fallot. So he had 4 things wrong with his heart and needed surgery, and he wasn't doing that great. So that was our actually initial, introduction into having a child with a disability, is that it was negative. Nobody congratulated us. It was all horrible. And then when I said to the nurse, okay, now I sort of know he's got Down syndrome, and now I sort of know that he's maybe has some kind of heart disease that I don't know anything about. Can somebody tell me what to do with this baby? And she said, oh, yeah. And she like kind of backed out, came back with a social worker, and the social worker said, I understand you don't know how to take care of this baby. And I said, yeah, you're right. I'm kind of overwhelmed. I said, and I'm a nurse too. I've worked at this hospital. I had worked at the hospital 3 years. I was the supervisor of the cardiac intensive care unit, and kind of wondering why none of my friends had come down to visit me yet. And this is why, because it was such a negative thing and nobody wanted to come in and they were isolated. Anyway, so the social worker said, well, since you don't know how to take care of him, she said, there are people that do know how to take care of him. I'm like, great. And she said, so these are adoption papers. And so if you and your husband would just sign here, we have a I'm going to cry. We have a foster mom that I can get a hold of today, and she can pick him up. And I'm like, get out of my room now. So anyway, that was my first experience. So I kind of prayed that would never happen to anybody else. So I continued to work at the hospital, worked in ICU, CCU, cath lab, kind of went about my professional business while raising my beautiful son and doing great with him, I think. And so I was with a patient who had developmental disabilities sitting in the hallway, an adult, and I always was drawn towards those patients anyway because of my son. And a lady came up to me who was actually one of the volunteers at our hospital, and she said, I really like the way you're talking to that patient. That's really nice. She goes, I had a daughter who died here. She had cerebral palsy. And she said, that's why I volunteer here, because I want to give back too. And she said, do you think you could teach these nurses how to take care of patients like you do? And I'm like, well, like right now I'm kind of the supervisor of the unit, so I don't know how I would do that. And then probably a couple months went by and I got called down to administration thinking that I was in trouble for something. And the administrator said, do you know that little volunteer Millie? And I'm like, yeah, I know Millie. We talk sometimes about our kids and stuff. And she said, well, she just gave $1 million to our foundation. And she said that there's a nurse that knows how to take care of patients, and we really want her to figure out how to teach your staff how to take care of these patients. So this is why... Be nice, right? So this is kind of how I fell into not my career path of what I intended to do with my career and my life. So what I do at the hospital, so what did I with with that money? So what I do is I coordinate, facilitate, and advocate. And so I help to promote clinical excellence by making sure that my staff or the staff has some training. And although I had no training myself, I had to go out and seek opportunities for training. So I went out and found some national organizations, DDNA, which is Developmental Disability Nursing Association, AADMD, American Academy of Developmental Medicine. I joined all of these, and so just so that I could get, some more training on these things. So another thing that I help to do is to provide accommodation for patients who need to be accommodated, obviously, because there are a lot of patients who have disabilities, and under the ADA, we are obligated to make sure that we are providing that kind of service for the patients. So, so I help to provide accommodation too, and I also can make referrals to ancillary departments, PT, OT, and all that. The other thing I do is help to make sure that we are ensuring legal compliance, and I'm going to talk a little bit about the regional center system a couple of slides from now. And then I try to make sure that we do individualized care planning with the patients to make sure that we are caring for them, knowing who they are, listening to the patient, keeping them safe, empowering them, and understanding them, and actually treating them equitably as far as, you know, we were just talking about how healthcare with this population generally is not very equitable, and so we need to focus on this. So it's kind of like anything else in healthcare. If you focus on an issue, it will get better, because our administration didn't really think that this was going to make a difference, or there wasn't really any value to it, and yeah, you just kind of go do that, you've got this money, go, you know, whatever. And I think they thought it was only going to last, you know, a year or whatever, but no, I just kept, you know, pounding away and saying, nope, we're going to do this and we're going to do that, and, you know, I'm going to keep trying. So this is what I do. So this is one, so the way I do, the way I obtain referrals, so I'm under a referral system because I'm like, well, how do I know where these patients are in the hospital? I don't have ESP, I just can't, you know, make rounds every day and figure out who they are. So we did determine a way to make referrals to me. So one of the ways that we were doing it was through the electronic healthcare system, through, well, our system at the time was Meditech, so they were able to do a consultation through Meditech, and I'd get a fax in my office. But now we've actually switched systems, so now I have to just get a fax or a phone call or word of mouth, or case management or social services calls me. And now it's turned around so that I'm the first person that is called, not the social worker. They usually call me first, and then the social worker's like, okay, I'm kind of back here, and if you need me for anything during this hospitalization, you call me. And they are very helpful with, you know, other kinds of resources, but not the initial, you know, getting to know the families and getting them the resources. So one of the calls I received was, and this is typically the call that I receive. I'm in my office, answer the phone, hey Doreen, we have one of yours up here. I'm like, one of mine? Oh, okay. Do you have a diagnosis? Do you have, like, what's his disability? They're like, we don't know. He's got some developmental disability, and he's screaming and yelling, and he's shaking the side rail, and we just need you to come up here right away because we can't do anything. He just got admitted, and we can't do anything with him. So I go up there, and I go, hey, buddy, what's going on? And he's shaking the side rail, and he's going like this, and the nurse said, you know what? He's been doing that to me ever since he got admitted from the ER. I can't get close to him. I can't put an IV in him. I can't do anything because he's shaking his fist at me, and I think if I get close to him, he's going to hit me. And I go, And I go, he's doing this? And she goes, yeah, like that. I go, you know what this is? And she goes, no. I go, that's the T sign in sign language. That means toilet. And he's telling you that he has to go to the bathroom, and he's nonverbal, so he's shaking his side rail to get your attention, because did you show him how to use a call light, or did you give him a call light? Did you accommodate his need for a call light, or ask him what he needed? Did you ask him if he has to go to the bathroom? Did you ask him his name or his nickname? And she's like, I don't know. And I said, okay, buddy. So I looked at his chart real quick, and it said that his nickname was Charger. And I'm like, hey, Charger, you got to go potty? And he's going like this. I put down the side rail. I sat him on the side of the bed. And she goes, wait. He can't get out of bed. He's on bed rest. I go, why is he on bed rest? And she goes, well, I don't know. And she goes, they're all on bed rest. I go, he's not on bed rest. So I got him up. I walked him to the bathroom. He sat on the toilet, had a very nice BM. I helped wipe him, put him back to bed, laid down. And she goes, how did you do that? I'm like, it took zero of my nursing skill to do that. So as far as, you know, the staff training, so I try to do personal guidance at the bedside with the nurses. So, and one way that I do that is the very first thing I do when I get a referral is that I make sure that I call whoever cares for that person. Do they live at home? Do they have a caretaker? Are they from a care home? And then, so I try to get as much baseline information about them as possible. One of the questions that I ask is, what day program do they go to? And in the beginning, actually the regional center was like, why do you care what day program he goes to? I said, well, I used to actually be on the board for the ARC San Joaquin, and we've got 6 day programs, and so if you kind of tell me what day program he goes to, I kind of know what his capability is, because I know if he colors, I know if he goes out in the community, I know if he, so it's really important for me to know what day program he goes to, so I know what kind of activities I can provide for him. So I try to incorporate their functional strengths and goals into our decision making. I identify what significant relationships are in their life, do they have parents? Just because they have parents doesn't mean that that's their significant relationship, because they may live in a care home and that parent may only go visit them on Christmas, and I really see that actually a lot. I once had a young man who came in with, he had testicular cancer, and we knew nothing about his family history, and then I started kind of digging, and I finally found a mother who lived in West Virginia, and she said, yeah, I had to give him up because he was just too much for me to handle. He actually had Down syndrome. I would have taken him home with me, but people have different situations, and it's okay. So anyway, she said, I told her that, well, he's going to have to get some treatment, some cancer treatment for his testicular cancer. And she goes, oh, his dad died of testicular cancer when he was 35, and this patient was 35. And I was like, okay, well, that gives us a lot of information. So we do try to contact people to get histories and get as much information as possible. And I also really try to make sure that we work in a team. And so that team, if physical therapy, occupational therapy, respiratory therapy, if those guys are kind of doing their job and I need more of a team, that I call on this team. And so this is our pet therapy that we have. And I had a young girl that another call that I got, hey, we have one of yours. She's got the covers over her head. She won't uncover herself. And so I went in with one of the pets. I found out as a baseline that at the care home that she resides at, they have a small white fluffy dog. And I'm like, oh, we have one on our team. So I called the person that owns the little white fluffy dog on our pet therapy team, and she came in and she just lit up. And so it was really pretty awesome. And then I do annual classes through our learning center. And so these were just some of the folks that I had from the ARC San Joaquin come in. This gentleman uses a communication device. So I wanted to make sure that, we are accommodating and teaching the staff that people do use communication devices outside the hospital, and this is what they use. I've tried to do accommodation by I call it by play, because sometimes if you have a surgical patient, what do we want to do with surgical patients? We want to get them out of bed. We want them to cough and deep breathe. And how do you tell that to a person who cannot comprehend those kinds of things? So I will get things like party blowers. I'll go in the room. I'll sing happy birthday. Even if it's not their birthday, everybody loves birthdays. I sing happy birthday, and I bring in a party blower and give them one, and then they start blowing it, and that's their incentive spirometry, and that's their cough, and that's their deep breathing, and it helps to still get to the goal that we're trying to get to, but we get there in a different way. So I do a lot of different things to try to accommodate. So I do what I say, speaking up for those who can't. And I use a lot of, again, assessment logic. I try to clue into the physical assessment. Like, for example, if they're drooling or not opening their mouth or refusing food, it could be because they have a sore throat, they're nauseated, they have a toothache. There's a lot of dental pathology with this population. They could have an infection. If they're refusing food, again, it could be because they might be nauseated, have abdominal pain, constipation, which is number one. The food might have a different texture that they're used to, or they're not sitting up in a chair. I have a lot of patients who have cerebral palsy who do they lay in bed and eat at home? I think not. So the chair that you saw earlier is one of the chairs I actually bought through our grant. It's a Tilton Space chair that has a tray on it that I use for my special needs patients, and I try to make sure that all those patients get up in that special chair so that they can eat while they're sitting up in their chair, because many of them, because they're so routine oriented, won't eat when they're sitting up. There's also legal obligations, and I have to go quick because I know I only have a couple of minutes here. And so, as you know, we are under the regional center system here in California, the Lanterman Act law. There's 21 regional centers in California. We are actually under the, it's called Valley Mountain Regional Center. You all here in your counties, your 9 counties, are under Alta Regional Center. And you have, I can tell you for sure, you have 18,000 consumers, and 65% of those consumers actually live in Sacramento County. So you have a large population right here. Because of the legal obligation, I have to do a lot of training with the physicians and nurses about the consenting process. And so a lot of you, if you're family members or work in the field, you know about the consenting process if you're conserved, non-conserved. And the law says under Welfare and Institution Code 4655 of the Lanterman Act that the regional center can provide medical consent for patients who are not conserved, who are in the hospital. They can't make decisions like do not resuscitate and those kinds of things, but they can provide us medical consent if we need a PICC line, go to surgery, whatever. And another really important law that I try to stress with my staff is Rosa's Law, which is a law that was signed, a federal law that was signed by President Obama that took the language, the term, that awful R word, the retarded word, out of the language. And so now we need to focus on person first language and then not using that word. And it was endorsed by the American Medical Association as well. That's just the Lanterman Act that talked about already. So anyway, so this is, so these are kind of the goals of my program, to make sure that we have patient-centered care, that that we respect the patient and the quality of life, that we build trust and confidence with our patients, supported decision-making, which is a big thing now, understanding cultural identities. We actually have a lot of patients who are Spanish-speaking, who have a lot of families who are Spanish-speaking, so we want to make sure that we are in congruence with the language, because even though we may be speaking in simple terms to that person that we think understands, we may need to be speaking in simple terms in Spanish to them. So we need to find out, those kinds of things too. And then, of course, obtain any assistive devices as much as possible in the hospital setting. So I hope that you got a little bit more understanding about how we should be treating people in the hospital. One of my biggest goals in life is to try to get this information out into, these guys are helping get information into the nursing curriculum and into the medical curriculum. We actually have residents, we have physician residents. We have a resident training program at our hospital now, and I just trained the residents on Wednesday and told them a lot of this information too, so that their focus now is a little bit different. So may the force be with you.
Oh, well, thank you so much, Doreen. My name is Dr. Eden Donahue, and I'm an assistant professor at California State University, Sacramento. So my focus is going to be on how we develop curriculum through a family engagement approach, because Doreen is in a very unique position, and not very many hospitals have a position or resources like at Doreen's facility. So we really wanted to look at how do we develop curriculum, especially around simulated experiences, through a family engagement approach. So I'm going to start off with a little bit of the doom and gloom, and we'll tell you how we're going to improve and some areas of improvement that are already happening. So we know that in medical schools there is a very big gap of education resources, especially around developmental disabilities. 81% of medical students say that they did not have any curriculum related or training related to disabilities in general. 81% of medical providers. That is a very, very astonishing number. 58% of administration at medical schools don't see developmental disability curriculum as a high priority. So not only do we have healthcare providers that aren't getting the curriculum, but it's also not valued on the administrative side. And as Diane discussed earlier, there are obvious inequities in their knowledge and skills related to people with disabilities. We also see very similar findings with schools of nursing. So we have healthcare providers and nurses who are inadequately trained to provide care for people with disabilities. And we target developmental disabilities at the pediatric curriculum, but we don't really talk about that lifespan approach. And as this population ages, healthcare providers need to have the knowledge, skills, and attitudes to be able to provide competent and comprehensive care. So the good news is that there are many organizations that are looking at developing curriculum throughout the United States. Doreen mentioned the American Academy of Developmental Medicine and Dentistry. We also have the National Curriculum Initiative, which is helping to develop and promote national curriculum. Here at a local level, UC Davis recognizes that this is an area of concern, so they have developed a specific class that looks at curriculum related to developmental disabilities and health. The downside of that is that right now it's an optional course. So people opt into the course, it is not integrated into the mandatory curriculum. So that is an area of improvement. So time and time again, we can see that if we develop educational events, curriculums, and opportunities, that we are able to kind of hit all those problems that Diane was talking about. So we can really improve health outcomes, quality of life, increase support staff, decrease family burden, as well as the financial burden related to healthcare services if we start where the healthcare providers are getting educated. And that's where we are focused right now. One of the first projects that we worked on was we held a education session in February at the UC Davis Medical Center targeted at bedside nurses who are kind of working with a variety of people. And it was an all-day education session, and we learned that the most important aspects of care were communication, a truly team-based approach, making sure that the patient is at the center with a family engagement approach, making sure that you really utilize a team approach, and then not only person-first language, but person-first care, and really truly embracing that idea of person-first. We also had various levels of family engagement, and during that session, it was very evident that the nurses were most impacted by what the families and patients had to say during that session. It was about an hour-long session in an 8-hour-long day, but that 1-hour session with patients and families was the piece that the nurses kind of took home with them, and that was the most impactful learning experience. So this is what an emergency department looks like. It's busy, it's chaotic. If I could add noise in here, I wouldn't do that to you guys because it would be very assaultive. So there are a lot of things happening in an emergency department that are overwhelming for any person, but especially with a person with neurodevelopmental disabilities. So our goal is to think about what knowledge, skills, and attitudes do healthcare providers and nurses need to help guide a patient and family through this very chaotic healthcare scene, because this is unfortunately what healthcare looks like right now in this country. So when we started to think about how we're going to develop curriculum, we kind of came up with this model. So I've talked a lot about knowledge, skills, and attitudes, and those are kind of the three fundamental phases that we go through when we're trying to learn a new concept. So we have knowledge, skills, attitudes, but I wanted to encompass it all in a patient and family engagement approach, because if we are developing curriculum about a population without that population, we're not going to get anywhere. So this is, and I'm going to go into the various pieces of this model as I go on a little bit, but this is what is really what we're looking at for guiding our curriculum. So we have knowledge. So over the past year, I've been involved with various education sessions for people who are already nurses. They already have their license, they're already working. So you can see that over the past year, we've educated over 200 nurses, which is great. But if we look at the healthcare systems that they're a part of, it is a very small section of people that we are actually targeting. Most of the people who attended these education sessions had some sort of personal experience that drove them to seek out that specific education opportunity. So we are missing nurses who really need the education, but they're not seeking it out. So that's where we want to shift our focus. So then we have skills. So we have whatever previous education they got in their nursing school. So how to put in an IV, how to put in an NG tube. We also have the experiences that they've had at their job site, but the area that we really want to focus on is the area of simulation. And simulation is what happens in nursing schools across the country, where we can create a safe learning environment for students to experience some sort of healthcare situation, and a whole group learns from it. So that way they can find out what skills they need in a future situation. And I'll talk a little bit more about simulation in a few more slides. So during all of these education sessions, I'm really passionate about patient and family engagement because I'm both professionally and personally involved with people with disabilities. And so at each of these sessions, we really looked at getting community and patient and family input before we delivered the curriculum, as well as during the curriculum. And as we're developing the simulation, it's not something that we are just developing and then going to run by the families. We are in constant communication with patients, families, and community organizations as we develop the simulation, because we want to make sure that it reflects the experiences as well as the desired outcomes of the simulation experience. And from the education day in February, it was really evident to me that although there was a lot of curriculum delivered during that day, that the most impactful experience was hearing from the patient themselves. And so this is what made me feel like when we're developing curriculum, if we can bring that kind of experiential learning into a simulated environment through a patient and family engagement approach, we are going to kind of hit that trifecta of knowledge, skills, and attitudes in a family engagement approach to really impact and change nursing care in hospital settings and community-based settings. So this is a definition of patient and family engagement, and it's not just patient and family engagement on a one-on-one level with the healthcare provider and patient. It really is a whole way of thinking about patient and family engagement through an organizational and systems level lens. So that's where we are trying to go. When we were looking at patient and family input, the main problems that Dian was talking about are communication and that team-based approach. And when we were talking to patients and families, that is what they also highlighted as the most difficult aspects of care, that there was miscommunication, unclear communication, and that they weren't really enveloped in a team-based approach. And so it's important that as we're developing the simulation, that we highlight how do you communicate with the patient and family, as well as with your healthcare team members, and to also make sure that you're really embracing person-first language and care, because we are at risk of having diagnostic overshadowing in healthcare settings, and if we just change our language and our view set of it being person-first, we automatically address the person as a whole and not just the disability, which makes us less at risk for diagnostic overshadowing. When we were looking at getting patient and family input, we wanted to make sure that we had varied backgrounds and experiences. So we didn't want just parents or patients with with one specific neurodevelopmental disorder. We wanted to get a wide variety of backgrounds and experiences. We also partnered with various organizations because we realized the value of community-based organizations such as the Center for Excellence in Developmental Disabilities and Autism Speaks, as well as the Developmental Disability Nurses Association. So right now we're in the development stages of creating a family and patient engagement approached simulation. So simulation is what occurs in nursing schools, and it's not just what actually happens during that simulated experience, it's actually a few phases of learning. And the patients and families have been involved as we've developed all phases of curriculum because that is incredibly important. So when we first start out, you have to cue the learner into what you're doing. So you have to give them pre-learning activities so that way they know what knowledge and skills to bring to the simulation day. And that can be things like case studies, readings, and other sorts of learning activities. And then when we start to go into the simulation, we have to give a background of the simulation experience. So we give them a brief background of the patient and the situation. And then we also reiterate that simulation is a safe learning environment. So this is a great environment because you can make mistakes and learn from them, which is one of the most important things in life as a human, but also as a healthcare provider, is you make mistakes and you learn from them. And we can do that in simulation in a safe learning environment. When the simulation is actually happening, it's usually only 10 to 15 minutes, so it's not a lot of time. So a lot of it is kind of building up to the simulation experience itself. There are usually 1 to 2 people in the room, either functioning as a nurse. You can have different roles in that experience. You can have a nurse, a healthcare provider, a respiratory therapist, so you can have different roles involved. But then you have the rest of the class, which is usually between 5 and 8 people who are watching the simulation. So not only the people who are in the room doing the simulation are learning, but their classmates that are outside are also getting that valuable learning experience by observation. And then you have one facilitator who's guiding the learning activities, the simulation, and then the most important part is the debriefing session. That is where the learning and the reflection and that change of knowledge, skills, and attitudes really comes full circle in the debriefing. And that's where we talk about what feelings or thoughts were happening, what did you do well, what were some areas of improvement, and how might you approach this situation differently if presented in a similar manner in the future. So this is how, like I said before, we are in the developmental stages of doing this. This is the first time that a patient and family engagement approach has been the guiding focus and principle of curriculum development and simulation development. So we're very excited about our next steps of piloting this program. And so we're absolutely looking for any feedback from the community. So that's kind of where we're going in curriculum, but since we don't have that developed and we can't just hand it out right now, what I want to talk to you a little bit about is some toolkits and some resources that healthcare providers, patients, families, community resources, anybody who is involved with or who has a disability can take these resources today and use them in their own life. So I want to quickly go over some resources that are available to you. And I believe that they're also available online. We have a handout that you have access to, which has the list of organizations as well as websites. So my background is in school nursing, so I utilize the Lucile Packard Foundation's Children's Health website a lot, and they really have a thorough and encompassing view of person-centered care. So on their website, they have this concept called shared plans of care, and in that there are kind of step-by-step guides on how a patient, family, and healthcare provider can really come together to create a cohesive plan of care that is person-centered. And in that, there's an identification stage. So what are the needs and the strengths of this particular patient and family and care plan? And what does access look like? And then what does the care coordination look like? What other people do you need on your team? What resources or referrals might you need to enact the shared plan of care? So it's kind of a very thorough way to look at a care plan with all the parties involved. So Diane hit on this a little bit, and I believe we have posters that we can, do we have the posters? Okay, we do have posters that you can look at called the Fatal Five, and so Diane referenced these a little bit earlier, but these are the most common, deadly, and most missed by clinicians. These are the most common conditions that are missed for people with neurodevelopmental disabilities. So the very first one is pneumonia and aspiration pneumonia, so getting a lung infection. The next one is what we call sepsis, or it's a generalized infection. The next one is dehydration, so not enough water. And these are happening in community settings, but also in hospital settings. Bowel obstruction, so we've kind of talked about the importance of toileting and being aware of the outcomes without regular toileting. And then gastroesophageal reflux, or GERD. So those are the 5 most common missed and fatal conditions for people with developmental disabilities. And these are what the posters look like. So you can go online and get these posters if you work in a healthcare facility. They're really easy to use because it has a description of what does this condition mean, what does sepsis mean, what are the signs and symptoms, so what should I be looking out for, who is most vulnerable, and then what can we do to prevent it, and how do we respond to that specific condition. So they're one-page posters that give you nice, clear, easy-to-use information about that condition. And all the posters down here at the bottom say, when in doubt, send them out. So if you are ever questioning, could this be a generalized body infection, could this be a bowel obstruction, get them to healthcare resources as soon as possible. So it gives you kind of nice guidelines on what to do. Since we talked about communication and how it is an issue and how we can hopefully increase it, I now want to talk about something called SBAR, which is an acronym for Situation, Background, Assessment, and Request or Recommendation. So this acronym in this language is what a lot of healthcare providers use to communicate with each other. So if patients and families also communicate in this language, we can all make sure that we're speaking the same language so that it's very clear what you want in your shared plan of care. So this is just a handout of some kind of prompts that might help you think about how would I use this tool in my day-to-day life. So if you are the family member or parent of a person with a disability, you're going to say, my name is Eden Donahue, I am the step-parent of so-and-so, and I'm calling because I have concerns about a cough. So that would be your situation. Your background would be, give what the patient's current medical condition is, and the assessment. So what has changed? Why are you calling? What are you noticing? Are you noticing that they're having difficulty breathing? Are you noticing that their coughing has increased? Be very specific with what you're seeing, either with yourself or with your loved one. And then end by asking a request. What should I do? Should I bring my loved one in? When should I follow up? So always end with a question or a request. So this is kind of a clear-cut way to get your message across to healthcare providers of what's going on with you or your loved one. The next one is a healthcare toolkit, and it has 2 kind of portals, one for patients and supporters, and then one for healthcare providers. So this is really nice because the information is geared a little bit differently towards patients and supporters versus healthcare providers. But this website has tips on healthcare, staying healthy. Specifically, we've talked a lot about your rights in healthcare, and so they have a specific section for patients under your rights in healthcare, as well as for healthcare providers, because I think that's where we get a lot of questions of what are the legal guidelines for a patient and what are the legal guidelines for a healthcare provider. So these are easy, accessible resources for both parties. In that toolkit, there are various worksheets and flowcharts, so how to make an appointment, what to ask for, what to request, what to bring to a healthcare visit. Also a symptoms worksheet to kind of guide you or the person that you're working with on what symptoms might be relevant for that appointment, and then an after visit worksheet. So what do you do after the visit? Because that can be a piece that is often either missed on the healthcare provider side, or it's unclear to the person seeking medical care what does the after visit look like. So there's worksheets on that website. So how many of you guys have heard of health passports? Woo, okay, a few of you. So health passports are a really great tool. They're, I'm going to kind of show you slide by slide how thorough they are, but they're available in English and Spanish, and they're really great for office visits, hospitalizations, anytime the person with a disability is interacting with healthcare. These guidelines and tips can really help healthcare providers provide good care. So the very first section is just kind of name, preferred name, and a picture. Then we go into communication. So can you kind of see a common theme here? Like communication is one of the highest things that we're trying to address as healthcare providers. So how do you communicate? So the person can fill in exactly how they communicate, whether it's with an assistive device, how often they use that device. So it's very clear to healthcare providers what tools they need access to in order to communicate during an appointment or a hospitalization. The next one are a little bit more looking at healthcare, so what medical relevant history is needed, what are your current medications, and any preferences on when you take your medication. Do you have a specific food, like white pudding, that you always have your medications with? That would be helpful for healthcare providers to know, because we want to make sure that we're delivering the medication on time, so that way we can help you in your healthcare journey. Any allergies? And then the next part of the toolkit goes into what does it look like when you're experiencing pain? Or if you get upset, what does that look like, so that way, as a healthcare provider, we can know that this behavior is more focused around pain, and this one might mean that you're more upset, and what are some strategies that we can use to help you regain that equilibrium. Then there's also a section about how do you cope with medical procedures, because if you are in an office visit or in a hospitalization, you're gonna have some interface with medical procedures. So what can we do to help you cope with some potentially invasive things that we might have to do, like IVs or x-rays? Then we talk about mobility needs, and then drinking, eating, and kind of hygiene. What are your needs there, and how can we best assist you in your normal routines? And then the last page is just kind of favorite foods, dislike foods, so that way we can make sure that you're getting adequate nutrition during your hospitalization, as well as any sensitivities. So some people have sensitivity to light, sounds, noise. If we know that, we can try. We're not going to be able to eliminate those in a healthcare environment, but we can try to minimize those as much as possible. So I really like that toolkit because it is very thorough, and it gives the healthcare provider a lot of information to provide really good care in an office visit or in a hospital setting. So Autism Speak also has a variety of healthcare resources. So they have a questionnaire online. They also have an emergency plan for people with autism. So that's another resource that you guys can use. So I kind of want to end on, a more positive note, because we started out a little kind of doom and gloom, but we, as a healthcare kind of team across the nation, we are really looking at how we can improve care. We know that there are obvious deficits and areas that we need to improve, but there are a lot of programs out there that are specifically focused on how to improve care, and one of them is through the UCSF Office of Developmental Primary Care, and they provide services called CART services that train healthcare providers, patients, and family members on how and when to seek medical care. So that's a really innovative program. They also have toolkits online that are available. So again, communication, common theme. So everybody communicates. Another one about sexuality and health, because that's often a piece that's overlooked for people with disabilities. And then looking at behavioral interventions for people with developmental disabilities. We talked a little bit about the innovative things that are happening at Rush University through Dr. Sarah Ailey. And what they're doing at Rush University is they're actually embedding care plans in the electronic hospital record. So kind of similar to what we were looking at with the health passport, there are specific care plans for people with developmental disabilities that are in the electronic medical record, which is where healthcare providers go to access information. They're also doing a lot of other great things. They're doing a pre-hospitalization and pre-procedure tour program, so that way people can tour the hospital before admission or before a procedure. And they also have a buddy system with university medical students to care for patients with neurodevelopmental disabilities. So they're really trying to kind of bridge the gaps in care. There are also a few national organizations, and those are all listed in the toolkit. We've talked about a few of them, the Developmental Disability Nurses Association, but I want to talk a little bit about the Alliance for Disability in Healthcare Education. So this alliance has created core competencies related to disability curriculum. And these are the 6 competencies that should guide developmental disability curriculum in healthcare, whether it's medical providers or nurses or dentists or whoever. So we're looking at frameworks for disability, professionalism, and patient-centered care. That's competency number 2. Legal obligations, looking at how we truly do a team and a systems-based practice and approach to care, clinical assessment, and then clinical care over the lifespan, because we know that care in the pediatric population is a lot better than those transition and adulthood. So how do we provide care throughout the entire lifespan of a person? There are also some guidelines from another organization if a care provider has to do some sort of immobilization or stabilization for a medical procedure. There are specific guidelines for how to do this in a safe and effective manner for patients with disabilities. And I think a lot of healthcare providers don't know that this resource is out there, and so it's a very good, offers very good guidelines for how to do that when you are working with a patient and family with a developmental disability. So I want to end on the most positive note, I think. I think it was just a few months ago we were at a conference, and we were made aware that there is going to be the nation's first institute to prepare nurses to care for people with developmental disabilities, and it's going to open at the St. John Fisher College in Rochester, New York. And that, again, was made possible through a very generous gift through the Golisano Institute. And so it's not created yet, but they have the funding, and we're going to start moving towards developing really thorough and comprehensive curriculum for nurses to provide care to people with developmental disabilities throughout the lifespan. So that is very, very exciting news for us healthcare and curriculum, and I think everywhere. So we wanted to, I don't know if Doreen, if you want to give a special shout out, but we wanted to thank the Special Needs Program, the Mildred Luck Lewis Foundation, many of our mentors here through the UC Davis Mind Institute, the LEND, as well as the SED and community organizations, and especially the patients and family members who have volunteered their time, have shared their stories. We look forward to a continued partnership with you guys, as well as the LEND interns who helped us bring all this information together and get the information out about how to provide safe, effective care for people with disabilities in the hospital setting.
The UC Davis Mind Institute was created in 1998 with a promise to find cures for neurodevelopmental disorders. Every day, our physicians and researchers come closer to fulfilling that promise. Their groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other brain disorders are helping children achieve their fullest potential. Please visit our website to find out more about current studies, upcoming events, and how you can help make a difference.